to have Dr. Kevin Winthrop joining us today. Kevin is a fantastic speaker. He's an expert in this field, and I'm sure he's going to enlighten us on the latest information on the best ways to diagnose as well as potentially treat patients who are going to get these biologic agents and the best way to prevent the disease. Kevin is an assistant professor of infectious diseases in ophthalmology and public health and preventive medicine at the Oregon Health and Science University. He's also a former staff for the infectious disease epidemiology division of the CDC with the TB elimination. And Kevin, we won't hold that against you. He has co-authored over 130 publications. He is a leading researcher in the field of TB and NTM, especially in fields in studies dealing with biologics. And today he's going to be speaking about TB and biologic therapies, their risk and prevention. Kevin, without further ado, all the way from Oregon, was just so happy to have you. Kevin, how's it going out there?
Good, Dave. Thanks very much. Can you hear me okay?
We can hear you great, Kevin.
Perfect. Well, thanks everyone for joining, and Dave, thanks for inviting me to give this talk. It's a talk I like to give, and these are the areas that I'm really active in terms of research and what I spend my time thinking about outside of normal life. And I apologize too for being a few minutes late here. I was in clinic, and of course the last patient showed up with an O2 sat of about 84 or 5 at 9:30 my time, so it was a quick turnaround to try to get here on time. So thanks for bearing with me, everyone. So that being said, I think I probably have 45-50 minutes of material to talk about, and then definitely happy to discuss things in more detail by questions. So why don't we launch ahead into the talk, and I think I have controls here. So those are my disclosures. Almost all this is drug safety work, either on data safety monitoring boards or looking at clinical trial data, trying to look for safety signals. That being said, let's talk about TB. So you all are TB people, or most of you probably on this call, and you know this map. So this is really a map probably for non-TB people to look at. But just as a reminder to start to talk, you know where the areas of endemic TB are. And I think to set the stage for this talk, most of these areas have not been areas where the drugs I'm going to talk about today have been used. The clinical trial development programs of many of these drugs have enrolled patients from some of these areas, so hence we know about TB risk with some of these compounds because of that. But in terms of widespread circulation, post-marketing use, most of these drugs have been used in the Western Hemisphere, North America, Western Europe. And this is now changing really in the last year or two, where generic forms or biosimilar forms of these drugs are being manufactured. And we're seeing more use in India and China and places like that where there's much higher background levels of TB. So this is an ever-changing situation, and I expect to see more and more TB worldwide as these drugs become more widely used. So TB pathogenesis, just to review, again, you know this, but most of TB is transmitted through inhalation, and once the TB bacilli is inhaled, the alveolar macrophage picks it up. Within the macrophage, of course, TB, the bacilli wants to be there. It replicates, and it eventually bursts out of the cell and spills and disseminates hematogenously. At this point, the body attempts to react with really, multiple forms of immune defense. Most of this is based on TNF alpha responses and interferon gamma responses. These are Th1 immune responses, and most of this hinges on your system or the immune system limiting the spread of infection by granuloma formation around the bacilli and intercellular killing of the bacilli. And again, these processes are closely linked to TNF alpha and interferon gamma. These important cytokines that can be, as you'll see, will be downregulated or inhibited in some cases by some of the therapies I'm talking about. And that forms the basis of our understanding of the risk of some of these compounds. I'll go into this in more detail. So the main goal for this talk is right here. I am hopeful by the end of the talk that you will have learned how to pronounce at least one of these drugs' names. I've spent months and sometimes years trying to get the pronunciations right, and it's not easy. And of course, these aren't the trade names; these are the generic names. But the trade names aren't much easier in some cases. The TNF blockers we have up above, and the ones in gold are the ones that have been around the longest, really 8+ years, 10+ years for infliximab, and etanercept, adalimumab was a few years later. I think 2006 it was approved around that time. But the bottom line is most of what we know about TNF blockers comes from long-term safety data, experiences, and observational studies with those 3 drugs. We know relatively little about golimumab and certolizumab because they're much newer to market. They get lumped in with the other monoclonal antibodies like infliximab and adalimumab, and we assume their safety profile is similar, but we really are just making an assumption. The etanercept is slightly different. It knocks out TNF, but it's a P75 receptor that floats around rather than a targeted monoclonal antibody that zeroes in on TNF. Then we have the other drugs. Abatacept, which modulates CD4 T-cell responses, rituximab, which depletes peripheral B cells, tocilizumab, which is is a blocker to the IL-6 receptor, so it downregulates IL-6 responses, and then ustekinumab, which is widely used in dermatology now for psoriasis, which blocks IL-12 and IL-23, and actually blocks the P40 subunit that's in both IL-12 and IL-23. So hence it downregulates that axis of the immune system, and I'll get into these things in more detail. Tofacitinib is not technically a biologic. It's actually a synthetic disease-modifying anti-rheumatic drug, or DMARD. It is not biologic because it's not a manufactured antibody or something like that, but it's a drug that inhibits what's called the JAK inhibitor, and I'll go into the JAK system later. I didn't know about JAK, I like to say, until a couple years ago, but I've become very interested in this pathway, and you'll see why in a little bit. Next slide. So this schematic is just meant to bewilder you, and you don't really have to look at it. I'm colorblind, so it doesn't mean a whole lot to me, but suffice it to say there's a T cell and a B cell, and there's all these receptor complexes on them. A variety of these drugs target some of these receptors. You can see on the left-hand side there, rituximab is the B cell depleter. It targets CD20, and it will annihilate these B cells. Atacicept, belimumab, these are other things that inhibit things called BAFF, which activate B cells, so they stop activation of B cells. And then you've got abatacept, which basically minimizes the ability of other cells to activate T cells. So if a pathogen is presented or your immune system is trying to react to something, the CD4 T cell takes a variety of signals to get it going. Abatacept interferes with that process. Dave, can I ask a question? Can you see my cursor, or is that not showing?
I'm not able to see that, Kevin. I think at the top where you see the arrow where it says drawer, right, now I can see it, Kevin. Great work.
There you go. So there's abatacept right there, and it interferes with this step where this ligand on the T cell is ligating itself to this ligand on the B cell, and this is what activates the CD4 T cell. But abatacept gets right in between there and prohibits that from happening. Great. Next. So before I get wild and talk about all these drugs with weird names, let's talk about prednisone. This is my soapbox part of my talk, and there's really no question that prednisone increases risk of a variety of infections, including tuberculosis. And this was talked about in CDC's LTBI statement and prior TB statements for years, but there was really never any data ever cited that was worth a darn to substantiate that until this publication in the rheumatology literature in 2006. And this was a general practice research database study where they took all the TB cases in England for a 10-year period, matched them to controls, and found that current glucocorticoid use or prednisone use raised the risk of TB about 5-fold. And there was a dose-dependent risk with higher risk at higher doses. You can see 15 milligrams here. You had an odds ratio of 7.7. So this was really the first study that I could find in literature that really solidly drew the line here. Since then, there have been other studies, but there's no question that prednisone is a bad actor. And one of the benefits of the biologic drugs, and I'm not going to go into this specifically, so I'll say it here, is that if you can start a biologic drug and get someone's underlying rheumatic disease in better control, for example, you can decrease or even take away the prednisone. And if you do that, you are benefiting the patient. So one reason these drugs, the biologics, look potentially less risky is that they can serve as prednisone-sparing agents. So I am much more concerned when someone starts a biologic but maintains their prednisone dose. That puts you at higher risk than if you were able to wean the prednisone down or off. Here's a classic X-ray. You are all familiar with this. I show this to my rheumatology audiences all the time, but again, point out the classic appearing right upper lobe, infiltrate, and cavity here. There's also cavity probably in the right middle lobe there. This is something I use to point out that at least half the patients, generally speaking, who develop TB in the setting have normal chest X-rays. Half this disease is extrapulmonary on average. So many of these patients will not have an abnormal chest X-ray or pulmonary disease. So what is the risk of TB? So this is the risk of TB with TNF drugs. And there's several studies now that have really firmly established this. They're in areas of low TB incidence. This is the UK study, the French study, and the US study. In the first row is the UK study. And what we see is these guys have, this is the British Biologic Registry. They have all these people that have started TNF blockers, and again, it's etanercept, infliximab, and adalimumab. And then we have people who also have rheumatoid arthritis, but are on comparator drugs such as methotrexate. And you could see that the incidence of TB in people on the anti-TNF drugs together was 95 per 100,000 compared to 0 in the comparator group. There you go. So 95 per 100,000 versus 0. So we know the risk is elevated. When, let me keep clicking here. In France, they did a similar study. They found the rate was 117 per 100,000. They did not have a background rate calculated for that study, but that's certainly elevated over the population-based incidence, which was around 12 or 15 per 100,000 at that time, if I recall. And in the U.S., we actually did this study. We found the rate to be 56 per 100,000, and this was compared to 9 per 100,000 in similar patients who were not on anti-TNF drugs. When you look at the individual drugs, we found what we now understand to be a well-known phenomenon is that the monoclonal antibodies were more likely to cause TB than etanercept. So I point this out in that etanercept certainly increases risk of TB. The risk was 39 per 100,000. That is above the background rate of England, which was about 12 per 100,000 at that time. But I also point out that infliximab and adalimumab were another 3- or 4-fold riskier in terms of the incidence rate of TB associated with those drugs. And we found a similar finding in our experience in the U.S., so I was happy to see these things. We found roughly half the rate, which was probably right, given our rate was roughly half of what it is in England. And we found, again, a 3- or 4-fold increase in patients on infliximab versus those on etanercept. And you can see again here, if I can figure out how to do the arrows, 83 to 91 per 100,000 for the monoclonals versus 17 per 100,000 for etanercept. And this is a little more information about that study. This study was done in the Kaiser Permanente Northern California database. And you can see that that we also looked at non-TB mycobacterium, so this is my chance to plug non-TB mycobacterium. This is part of the mycobacterium family. It's my opinion that we should be mycobacterium people. We shouldn't just be TB people or NTM people. We do lots of NTM work in our daily TB jobs in terms of ruling out NTM in the lab and in people, and often treating people with NTM until we find out whether or not they have TB. NTM is a bigger deal in this setting in the U.S., but again, as a mycobacterial person, I can show you that in the general Kaiser population that NTM was more prevalent. It was about 2-fold more prevalent, and those rates are about 5 per 100,000 versus the TB rate was 2.5 per 100,000. Once you look at older individuals, this disparity grows and the rates grow. When you look at RA patients not using TNF drugs, the rates were, again, double NTM, about 20 per 100,000 versus about 10 in the TB group. And when you looked at the RA patients, this is rheumatoid arthritis patients on TNF blockers, you see the rate about 100 per 100,000 for NTM and about 50 for TB. So the rate certainly increases for all mycobacterium in this population with TNF use. So the question has been asked, and there's been a variety of studies to look at this. So why do infliximab and adalimumab cause more TB than etanercept? And there's lots of theories about this, and I kind of drew a line through a lot of these theories because I think the bottom two are really the ones that explain the difference. And that has to do with these drugs can downregulate interferon gamma differentially, and they can also penetrate granulomas differentially. And I'll show you some of that data. So this was some of the earliest data. This is in vitro data where TB culture filtrate in vitro was looked at using blood of patients on etanercept, adalimumab, and infliximab. And you can see that the stimulated responses of T cells was more diminished in the patients on adalimumab and infliximab. So this is the amount of interferon gamma that was produced in the presence of TB, and you can see a much greater downregulation for the monoclonals as compared to downregulation, but a more modest downregulation with the etanercept. Interferon gamma is, of course, important in controlling TB, and so again, this might explain why there's a difference between these drugs. The other study that I like to talk about is the Plesner study, and these were mice who had, up here they had acquired new infection of inhalation of TB. So these were mice, so in A and B up above, these were mice that were, let's get back to where I'm going here. These were mice that were given a new infection of TB. And you can see this is a survival curve. As you go along here, no matter if they were on etanercept or infliximab, everybody died at about 21 days after infection. And this was the bacterial burden in the lungs. You can see it rose no matter what drug the mouse was on. And this model, however, in C and D, this is different. This is the latent infection model. So these are mice that have chronic latent TB infection, and when you give them these drugs, something different happens. The ones on infliximab all died very quickly. The ones on etanercept, about 60% survived. And again, you see a difference in bacterial burden. It's much higher in the infliximab-treated mice, lower in the etanercept-treated mice, and the control mice. When they did autopsies on these mice, what they found was, you can just read the bottom line here, that the lung pathology differed. That etanercept penetrated the granuloma to a much lesser extent than the monoclonal. So this may be another clue as to why there's a difference here. Perhaps infliximab is just more, penetrates the granuloma better and interrupts cell-cell signaling to a greater extent than etanercept does. Next. Here's another piece of data that also might explain why the monoclonals do a better job of causing TB. And this has to do with CD8 cells. And it's been shown that these CD8 cells directly produce what's called perforin and granulysin. And these two things, this is perforin on the left, granulysin on the right. You can see that before modulation with infliximab, the levels are here. With modulation, they go down. You see this decrease in these cells that produce these products, perforin and granulysin, which are directly anti-mycobactericidal. They will kill TB, and this is, again, part of our defense system against TB. These are probably modulated to a much greater extent with infliximab than etanercept. The authors didn't study that necessarily, but we know there's membrane-bound TNF that is important in these responses, and infliximab tends to inhibit membrane-bound TNF much more than etanercept. In fact, etanercept doesn't. So this is another potential explanation. Next. So I've spent some time talking about that, but I want to drive home the point that it really, it's almost a moot point. All these drugs cause TB. Etanercept increases risk of TB, but I do believe it does so to a lesser degree than at least infliximab and adalimumab. The other two monoclonals, which I mentioned, golimumab and certolizumab, we just don't know. They get lumped in here, but the bottom line is everyone needs to be screened before they start these drugs, and everyone should maintain vigilance for TB during therapy with any of these drugs. I show this slide. This was a slide that Madhu Pai helped me put together years ago. It's completely out of date, but I guess I decided it wasn't worth updating. So I just show it because the same heterogeneity in recommendations exists today as it did several years ago when I put this slide together. And you can see here on the left that these are different agencies or countries that have issued guidelines, and you can see what year they were. Some of them are quite old, some of them are newer. We also then wanted to just show that there's differences in opinion here. The original BTS guidelines recommended really no initial screening, but just treat people from highly prevalent regions with empiric INH. They were worried about false positive skin tests in people with BCG. They were also worried about false negative skin tests in patients who are allergic and immunosuppressed. Other groups have moved to recommending the IGRA, primarily due to the concern of false positive skin tests. Some people have a two-step procedure with skin tests, and actually the Spanish still do this to my knowledge. They use a two-step skin test, despite the historic use of BCG in that population. There's a variety of other nuances here, but the bottom line is there's heterogeneity, and that's the point of the slide. And it probably, the best way to screen probably depends on where you are in the world, and it depends on two factors, your regional use of BCG and your background TB prevalence. And I'll get more into this in a second. So let's talk about the IGRAs. So there are two IGRAs to choose from, the T-spot TB test and the QuantiFERON in-tube. These are both good tests in my mind. They're very similar in their qualities and in what they attempt to do. And clinically, I tend not to distinguish between them because I think they accomplish largely the same thing. You're all familiar with how IGRAs work, so I won't go into them. But of course, they were designed to be much more specific by primarily not turning positive due to BCG. So the antigens, of course, contained in those tests have a much higher specificity for TB than PPD does, and so therefore you do not see this false positivity due to BCG. One question has to do with sensitivity, and really when you're screening immunosuppressed patients, to me the name of the game is sensitivity. I'm willing to err on the side of a few false positives if I pick up more true positives, and this is how we have approached our life as TB people for a long time now in terms of screening immunosuppressed or higher risk populations. And this to me was the most elegant look at this issue, and this was a case control study in Peru where there was heavy BCG use in both groups, and there was two groups of people studied, the rheumatoid arthritis group, about 100, and about 100 controls. And I will point out that in the RA group there's quite a bit of prednisone use, whereas in the control group, of course, there's no prednisone use. And what this study suggested was that the QuantiFERON was more sensitive than the skin test. And what drives that conclusion is the fact that in the control groups, about 60% of people reacted positive to either the skin test or the QuantiFERON. And that is consistent with other studies in Peru suggesting 50 or 60% of people there do have positive skin tests. In the RA group, however, the rates or the proportions of positives were much lower, only 27 with the skin test and 45% with the QuantiFERON. So much higher in the QuantiFERON compared to the TST. So the QuantiFERON was a bit closer to the controls, and this difference between 27% and 45%, this was fairly large. So the idea was that the QuantiFERON was picking up more true positives here and was more sensitive. And I can tell you without, spending an hour going through all the studies in this setting, that there's no question prednisone causes false positive skin tests, and it also causes prednisone causes false negative skin tests, and prednisone also causes false negative IGRAs. But my sense is that the IGRAs hold up slightly better under the conditions of prednisone use as compared to the TST. I do think probably IGRAs are slightly more sensitive in this setting. That's a hard thing to prove because we have no gold standard for LTBI, but if you look at all the data, again, that would be my summary. So let's talk about more how to screen. And the way I recommend screening directly is a result of several studies, which I'm about to describe, and it also really takes into account a priori probability. If the patient has risk, you need to screen to a different degree or a better degree than if the patient doesn't have risk. So let's talk about this more specifically. So this is the Kleinert study from Germany. Most of the people in this study had no BCG history, and what really bothered me about this study was the following. They took 1,529 rheumatology patients prior to TNF start, or biologic start. Actually, I think it was all TNF blockers. But prior to start, they screened them with both a skin test and an IGRA. And you can see 11% had a positive skin test and about 8% had a positive IGRA. However, there was very little overlap between the two groups. So very few people were positive on both. And when you looked at people that were positive on the skin test but negative on the IGRA, which is this group in the Venn diagram here, the problem is that a lot of these people lacked BCG, and a lot of them had really big skin tests, like over 15 millimeters, yet they were negative on their IGRA. It's really hard to blow this off. I mean, someone has a 15 millimeter skin test, they have no history of BCG, they have no reason to have a false positive skin test, yet they have a negative IGRA. I don't know what that means other than I would be worried about putting that person on a TNF blocker. These are really, to me, positive people, but they're discordant, they're positive on the skin test, negative on the IGRA. So what do you do with these people? I think you have to call them positive. Next, so in France, basically the same thing happened. And I love this French study because what they did was they took almost 400 people. They screened them with all three. They used a skin test, a T-spot, and a quantiferon. And most of these people had a history of BCG. These were the disease groups. AS is ankylosing spondylitis, rheumatoid arthritis, and inflammatory bowel disease. I'll tell you that the T-spot and the quantiferon concorded fairly well. There was a pretty good level of agreement between the two, which is generally true of most of these studies. And then in terms of the skin test, there was this group of people that had a greater than 10 millimeter skin test. So they really were, quote unquote, positive. But again, most had BCG history. Most of these people were negative, but they were negative on both IGRAs. They weren't negative on just one, but negative on both. And if you look at that group, almost all of them were given TNF, that TNF-I is TNF inhibition or inhibitors or TNF blockers. Most of these were given TNF drugs without INH, and none of them developed TB. So I think there was something special about this in that they used all three, and if you've got a positive skin test but you're negative on both quantiferon and T-spot, that's probably more reassuring than just being negative on one. And again, these people, distinct from the German study I just discussed, these people had a reason for potentially having a false positive skin test because they had BCG. Next study, and this is the best study. This is the golimumab experience. They screened over 2,000 patients in a development program for golimumab, RA, psoriatic arthritis, ankylosing spondylitis. They screened them with both a skin test and a quantiferon intube. 5 people developed active TB. All of them had screened negative at baseline, but actually when you looked at that data, 2 of them were probably positive on their skin test. They were negative on quanti, but positive on the skin test. One had a 5 millimeter and one had a 15 millimeter. But they were judged negative by local standards because these were thought to be BCG associated reactions. So really when you look back, 2 out of those 5 probably should have been picked up as positive, and they were picked up by the skin test. Of the 317 people who screened positive, however, I thought this was great. They put them on INH and they put them on golimumab simultaneously, and they were all treated with 9 months of INH and nobody developed TB. That's important. But when you look back at the screening results, this is also important, and this is problematic. Again, similar to the German study I showed you, there's very little overlap in between people who tested positive to one versus positive to the other. So this group here, this is the BCG group up here. So you see very little overlap. You see all these people are TST positive, this group that's quantiferon positive, but very few that are positive on both. And, you know, if you ignore the lower half of this figure and just had the top half, you would say, oh, well, this makes sense. These people all had BCG. So this group here, most of these, or all of them, are probably false positive skin tests. The problem is when you look at the people who lack BCG, and that's the lower group here. When you look at this group, you see the same phenomenon. You see very few people who were positive on both, and you see this big group of people that were TST positive but were quantiferon negative, and you can't blame it on BCG because they didn't have it. And in fact, when you look at that TST group, again, a good proportion of these patients had reasonably sized TSTs, meaning greater than 10 millimeters. So this is problematic to me, and this tells me that neither one of these tests on their own probably pick up everyone at risk. And it leads me to the following screening recommendation. And I've published this. This is my recommendation. And it's not necessarily the way to do it. It hasn't been studied for cost effectiveness and things like that. But it, I think, really just more illustrates how I think about screening. So the most important thing in the world for this sort of thing is risk factors. What is the a priori probability? And if someone lacks risk factors, you really probably don't need to screen them. But they're going on these drugs, so you should screen them. And but I don't try very hard to screen these people, meaning I don't think they should be positive. So I do think about their level of immunosuppression. If they're not very immunosuppressed, then I would just use an IGRA. If they're heavily immunosuppressed, you might just be fine using one of these tests as well. But I talk about a dual skin test approach here. Let me give you some real patients here. So this is my patient from Switzerland, and she was a woman who came to me, and she was in her 50s. She'd had BCG in the past, and she had no risk factors. She'd been in Switzerland her whole life, and now she's in Oregon, two places where there's virtually no TB. And so, you know, the chance that she's been exposed to TB is almost nil. The fact was is that she had already had a skin test. It was positive. And I saw her, and I did an IGRA, and it was negative. And I decided, you know, given the fact that she had no risk factors, she wasn't very immunosuppressed either because she hadn't started any of her therapies yet. I thought I could get away with an IGRA alone, and so I deemed her negative. Also, like all good Swiss people, she had a vaccine card in her wallet from 40 years ago showing me exactly when she'd been vaccinated and with what, every vaccine, including BCG. So I was relatively reassured that that was her history, and I blamed her 5 millimeter skin test on her BCG, and I felt comfortable doing that. That's this side of the paradigm or algorithm. Now, if you go to this side with a positive, so someone who should be positive, and this is my patient from the Philippines, he was in his 30s, he was an Intel engineer, he's from the Philippines, a place where it's probably a coin flip whether you're infected or not. He was on 60 milligrams of prednisone a day, so now we're here at this box, heavily immunosuppressed. His ophthalmologist wanted to put him on infliximab, so I was to screen him. I screened him with a skin test, it was negative. I screened him with an IGRA, it was negative. And then, so he, you know, got a dual screening, and then there's a little footnote here that was very CDC-like, I thought. I like this little recommendation. If you go down to the fine print, it says, for patients with risk factors and who are immunosuppressed in whom false negative results are more likely, consider repeating a screening test with one or both tools. I like this advice. So I followed my own advice, and I started back up here, and I re-screened him, and I screened him with both again, and he was negative on both again. So now here's a guy who it's probably 50% chance he's infected, given he's from the Philippines, but he's on 60 mg of prednisone, and he's been negative to both tools twice. So I told him what I thought his risks were, and I gave him all his probabilities and statistics, and he was an engineer. We talked about INH and how you know, there's a risk of hepatotoxicity, but it's minimal in someone his age, blah, blah, blah. We went through everything, and he decided in the end he wanted to take the INH. He in fact, calculated everything himself. He had a calculator, and he was an engineer. So he told me he thought it was in his best interest to take INH. I said, great. 3 months later, he'd weaned off his prednisone. He was on infliximab. I repeated his screening test, and he was positive, and that was with an IGRA. So, you know, this is an N-of-1 experience. You can't live your life this way, but it illustrates how I think about this. This is a guy who should be positive. He's really immunosuppressed. I just don't know that I can trust his tests. And so this is someone I would probably screen more closely or quote-unquote more aggressively by repeating tests and using a dual test methodology as compared to someone on this side of the paradigm, someone in Portland, Oregon necessarily who has no TB risk factors. I think just using one of these tests, and I would probably choose an IGRA because I do think it's slightly more sensitive in people who are immunosuppressed. I would screen with one test, and I would not repeat the screening. So I hope that makes sense, but that's how I think about this. And in fact, the American College of Rheumatology thinks about it similarly, probably because I was the consultant on these recommendations, but they recommend prior to Biologics start something similar. They say use a skin test or an IGRA, but think about repeating or rescreening if they have TB risk factors and they're immunosuppressed. And again, largely the same algorithm. What about serial screening? I'm asked this question all the time in endemic areas. Patients are at risk for new exposure, and so there is an idea that maybe you should screen these people every 3 months or every 6 months or every year or something like that. There's really very little data out there to guide us how to do this. There's one study from Taiwan that's illustrated here. They did do this every 3 months, and they did pick up 4 or 5 cases of TB who, their quantiferon responses, I think they use quantiferon in this. I think it might have been gold, in fact, not into, but they did find an increase in interferon gamma production, and it coincided with their diagnosis of TB. My only problem with this study is that, they basically did these tests when the patients were starting to feel sick already from TB, which was right here in the time course. So it's not like they did them back here and they predicted that they were going to get TB and they prevented it, but they just more, kind of helped them diagnose it at the time. So I'm still perplexed. I'm not quite sure at what frequency we should be screening someone in a highly endemic area, but I think it's a reasonable idea, and I think it needs further study. LTBI treatment, you guys know all this. There's one study from Spain in the second bullet there that has showed that if you screen people, start INH, and start their TNF blocker 1 month later, you can reduce TB rates, and they showed an 83% reduction in TB rates associated with infliximab. There's really no other studies, I think, that are population-based that show kind of this before and after type of experience, but this is the one study that shows it, and I think it's intuitive, and we all think the rates have declined since screening has become widespread. LFT testing, just take note, a lot of these patients are on methotrexate, so you've got to be aware of it. The new therapy option, 3IR. So this has not been studied necessarily in this setting. It's been studied in the non-immunosuppressed setting, and that's the data presented here from the Sterling paper in New England Journal. This is, of course, CDC study of 3 months of once-weekly INH and rifapentine directly observed as compared to 9 months of INH. And you can see the TB rates in the two arms were different. They were actually statistically similar, but about half in the combination therapy. So the INH rifapentine, the rate was 0.07, and the rate was about double that in the isoniazid arm. So we know this regimen works. It's as safe as 9 months of INH. I have also used this in my own practice. There's one large trial in the HIV population that showed that this was also effective. I've used that trial to make myself feel better about using it in immunosuppressed patients. So far, at least anecdotally in my clinic, I've probably used it in several dozen of these type of patients, and they've done quite well. I think if you've ruled out active TB and they have latent infection, I don't see why this regimen would be any riskier in someone who's on or going on a TNF blocker necessarily. So I think it's a good regimen. Again, it's a lot easier to finish for some of these people. But again, you have to be aware of drug-drug interactions with the rifapentine, et cetera. I show this mainly in rheumatology talks to tell the rheumatologists just how smart they are, but this was a study that looked at European countries, and this is the G5 countries, which I don't even know what that is. I'm just kidding. I think I know what it is, but I think it's the biggest 5 economies in Europe, and I don't know who it is these days, but probably Germany and France and England, and I'm not sure who else. These are the non-G5 countries. The bottom line is, in all these countries, rheumatologists are fairly aware of TB screening guidelines, but rheumatologists compared to GI docs and dermatologists are doing a slightly better job in terms of being aware of the guidelines and following the guidelines. These are the percent of people who reported following guidelines in this survey. So it's about 80 to 90% for rheumatologists, and it's about 10 points lower for the other specialists. This probably reflects the fact that these drugs have been around the longest in rheumatology, and that subspecialty has really plowed the way in terms of helping develop the screening guidance around using these drugs. So So let's talk about the other drugs. Rituximab. I told you already this is a peripheral B-cell depletion drug. And what that means is you have central B cells in your bone marrow and you have peripheral B cells that float around. This takes all of those out. There were no TB and RA clinical trials or really necessarily reported in its use in B-cell lymphoma. We did a survey a few years ago of ID specialists in the U.S. and we uncovered eight cases of mycobacterium. Some were TB, some were NTM. There's at least one animal model that suggests when you knock out these B cells, you do promote TB survival in the mouse at least. So I think theoretically there's possibility that this drug does increase the risk of TB, although if it does so, it's quite minimal because we haven't seen it in human studies. But this B cell is part of the granuloma, and presumably it does have some importance in that setting. So again, I always think about it. I have seen some pretty odd NTM cases. We've published these cases. So I do think there's probably something here, but it's just not likely the risk that we see with TNF blockers. Abatacept is the CTLA-4 ligand. So this is that drug that gets between the T cell and B cells and other things that allows T cells to become active, but it really mitigates or dumbs down that response. There's at least 12 cases of TB reported in post-marketing data. The rate's 90 per 100,000. Of course, that post-marketing data is from open-label studies that have been conducted all over the world, so I don't really know what to make of that rate. I don't know if it's elevated or what it should be, quote-unquote. But the bottom line is you should screen patients before you put them on these drugs, and again, I think TB is possible. There is a murine model that's looked at this, and abatacept did not, distinct from the TNF blocker studies and the rituximab study I just mentioned, abatacept in mice did not influence the mouse's ability to control TB. So maybe this is a safer drug. We think about that actually with a variety of infections, and it's a thought. There is some data behind it. The data I'm showing here is the animal model I just mentioned. Up here in A, this is the mouse survival, and you can see the thick line here. The ones on abatacept seem to do just fine, and the ones on TNF drugs all died pretty quickly. And these were MTB-infected mice that were treated with both. And the rest of these are just CFU counts, and they go along with the same story I just told. There is one head-to-head RCT of abatacept versus infliximab that seemed to suggest a higher percent of opportunistic infection in the infliximab arm as compared to the abatacept arm. That included 2 cases of TB in this arm. I think from a population-based standpoint, we've looked at general bacterial infections. We've looked at opportunistic infections in the way of herpes zoster, which all these infections seem to be slightly lower in abatacept, although not by much. But I do think there probably is some safety difference with regards to these type of infections between these compounds. So IL-6, this is a cytokine that is an upstream pleiotropic cytokine. I had to look up that word, pleiotropic, years ago when I put this slide together. But it means you do everything, or you do lots of things to lots of things from lots of places. And that basically sums up IL-6. It's secreted by a lot of different cells, T cells, macrophages, other activated immune cells, and it stimulates both Th17 development and B cell development. Th17 is a specific subtype of T cells, and I'll show you a diagram here in a second which should help you understand what those do. If you look at animal data with TB and the IL-6 in mice, it's all over the place. These are all different types of infections. The TB is highlighted there. Some of these studies showed an increase in TB-related mortality in the mice when you blocked IL-6. Some of these actually showed that there was no difference. When looking at some of these other bugs, sometimes IL-6 blockade improves survival, and sometimes it hinders survival. So it's really all over the case. And it's all over the place. My assessment is that it probably depends on when you inhibit IL-6. If it's close to the time of infection, it may be very different than if it's long time after infection. Human data is as follows. We have a drug called tocilizumab, which is listed here at the top, and this is the drug that blocks IL-6 and blocks the receptor to IL-6. And in population-based studies, and this is again long-term extension trial data, meta-analysis of clinical trial data, the rates of opportunistic infections were 230 per 100,000. That's about the rate we see in various studies of TNF blockers. There was several cases of TB in that series. In Japan, where we have a good observational study, we didn't show, but others showed the TB rate to be 220 per 100,000. And this is very similar to the rate that was seen in the TNF blocker studies there, also post-marketing. And it's about 10 times the background Japanese rate. So when I'm asked, what's this drug look like, it looks pretty similar to the TNF blockers to me in terms of their ability to cause TB and actually some of these other infections like pneumocystis and zoster. These are pretty similar rates as to what we see in the TNF literature. Now, if you look at in vitro studies and animal studies, however, the IL-6 blockade doesn't seem to be as risky. I just showed you the animal data. It's kind of all over the place and uninterpretable. This is an in vitro study that was similar to one I showed you before that compared etanercept, infliximab, and adalimumab. This was an in-dish study looking at interferon gamma production stimulated from MTB antigens in patients with active TB, and they were exposed to these various compounds in the dish. And the ones with tocilizumab in the dish produced a lot higher levels of interferon gamma as compared to the ones with etanercept and then infliximab. And this level with tocilizumab, I drew this red line here. You can see that the control, the no biologic group, and the TOS group were pretty similar, and they're definitely higher than those with the TNF blockers. So there's an idea that tocilizumab doesn't downregulate interferon gamma to the same extent. So maybe it's of less risk. But again, the human studies suggest it's pretty similar. This is the mouse model study that is probably the best study that looks at this. But again, this is active, or this is, I should say, new infection TB. These are mice that were given an inhalational dose of TB. This is distinct from the latent TB model. And I wrote this here, would a chronic TB or latent TB model give you a different result? It's possible because, again, IL-6 is this immune modulatory cytokine, and it may behave differently early in the time course of infection as compared to later. What this acute TB model showed was that the mice given the TNF blockers died pretty quickly. There's a survival curve, and the ones given the IL-6 blocker survived to a much greater extent. And these are CFU counts of TB in different organs, and you see similar differences. You see IL-6 is the black thing here. I'm sorry, that's the control. The IL-6 is the white bar, and this is the TNF bar. So you can see the TNF blockers much higher CFU bacterial counts than compared to IL-6 blockers and the control arm. So there is some suggestion here that the tocilizumab might be safer, but again, the rates we've seen in TB studies seem pretty similar. And again, I guess in the end, it doesn't matter. To moot point, you need to screen these people before they start this drug, just like any of these other drugs. So the last few minutes here, I'll focus on a couple other drugs of different mechanisms. So this is IL-12 and IL-23. There's a subunit called P40 that's shared between these two. And when you have a naive T cell, it either differentiates into a Th1 cell or a Th2 cell or a Th17 cell. I mean, these are some options for that naive T cell. And the Th1 response we know is very important for Mycobacterium. The Th17 response is really important for Candida, staph, extracellular bacteria. It drives neutrophil responses, but it may also have some importance in TB immunity as well, and I think that's been shown. Let's see if I can get this thing to go. Yeah, so when you block Th17, you can downregulate these IL-17 molecules, which then downregulates responses that are really directly related to Candida and Staph aureus, yet we don't necessarily see an increase in those infections in patients on this drug. I really worried about this drug. I thought we were going to see mycobacterial and salmonella infections. And why did I think that? Because when you inhibit this P40 subunit, potentially you're going to inhibit, where's my little arrow? You're going to inhibit IL-12 and IL-23, and IL-12 is really important for this right here, going up to the Th1 response. And IL-23 is important for going down here. There's IL-23. So if you're blocking both these pathways, again, really I worry about blocking this Th1 pathway. You're going to downregulate interferon gamma, TNF alpha, et cetera. You're going to get more TB. And we know from humans with IL-12 or 23 defects, P40 defects, deficiencies, autoantibodies, et cetera, those people get these types of infections. They get disseminated salmonella infections and they get mycobacterial infections. But we have not seen that in patients on ustekinumab. There's really, to my knowledge, no cases of TB associated with this drug, at least in the clinical trials and in the open label experience of this drug. There's over 3,000 treated patients. Suffice it to say, all these patients were screened, so that is something that's important to recognize. And perhaps those studies weren't done in high TB endemic areas either. And this is a different population than the RA population, which makes up most of the studies I've mentioned or showed earlier. But bottom line is we just haven't seen the types of infections I was expecting, and I'm not sure why that's the case. So the Brave New World, to end the study, or this talk on a few studies of JAK inhibitors. And I made the joke earlier, I didn't know about JAK until like 2 years ago. Now I know a lot about JAK, and I spent a lot of time thinking about JAK inhibitors. And these are kinase inhibitors, or I'm sorry, these are kinases, intracellular kinases. You have JAK, you have SYK, you've got P38, you have MAPK, you have a number of kinases that sit in your cell that have receptors to the outside world, and when certain pathogens bind those receptors, it turns on JAK. JAK then makes STAT, and STAT goes into the nucleus and basically drives your intracellular machinery. It turns on DNA transcription, and it makes everything you need, like TNF, IL-1, IL-6, you produce new blood cells, etc. I mean, this is what drives your DNA replication in the cell. We know that a number of inflammatory pathways and responses are mediated through the JAK receptor, and so there's been a big emphasis at trying to block JAK. People have also blocked SYK. It didn't turn out so well. The SYK inhibitors have been canceled, at least as far as I know for now, due to infection. And I don't think the P38 inhibitors have panned out very well in terms of efficacy, but the JAK inhibitors work really well for psoriasis. They work really well for rheumatoid arthritis. But there is a distinct infectious signal coming from those compounds. The only one that we really know about and that is published is tofacitinib, and this blocks JAK1 and JAK3. There are 4 JAK receptors, and this blocks JAK1 and JAK3, and these things go together at the cell surface. They form combinations or dimers. And I did this study. We looked at the clinical trial data from North America, Western Europe, and globally where these trials were run, and we saw a TB rate of 173 per 100,000. Most cases were at a 10 milligram BI dose, and the 2 doses were 5 or 10, so we did see this dose-dependent signal. And all these cases screened negative prior to trial entry, and there was pretty good length of time between trial start or drug start and development TB. So I think probably at least a good chunk of these cases were probably newly acquired during the course of the study. And you can see, let's see, there we go. You can see these rates. It's hard to see, but we calculated the rates in the trial or the development program according to the background incidence rate of the country. So we have low, medium, and high. So the U.S., of course, is low. Western Europe's low. And this was defined as less than 20 per 100,000. And when you look at the rate in that group, the rate in the associated with TOFA was 0.037 or 37 per 100,000. So it was elevated, but we had only 1 case from those regions. The rate in the medium regions of prevalence, which was basically between 20 and 50,000 per 100,000, the rate was similar. It was 34 per 100,000. But the rate in the highly endemic areas, we had 10 cases in those areas, and the rate was 781 per 100,000. So, and those were mostly in China, India, and Southeast Asia. And so I think the rate's elevated with this drug, and there does seem to be some dose dependence associated with it. The good news of this study was I really liked what they did, and we have not published this yet, but it was presented at a major conference. There were 209 patients diagnosed with LTBI due to screening at the start of the trial. All of them went on INH for 9 months, and after 1 month they started tofacitinib. They all finished in 9 months, and none of them developed TB, and no one had hepatotoxicity associated with their INH. So this showed that you can screen and treat TB while you put someone on this drug, and I think this is important. The last bullet there, that INH is the therapy of choice. You should know that rifampin and tofacitinib have a drug-drug interaction. You can't use them together. Rifampin will cut down tofacitinib use, bioavailability, so tofa won't be very active. So you probably won't hurt their TB, the efficacy of rifampin, but you will hurt the efficacy of tofacitinib. So my conclusions: TB risk with the anti-TNF therapies is clear. The newer biologics, I think it's a big question mark, but the animal data suggests less risk for tocilizumab and abatacept, but the human data suggests similar risk for tocilizumab and probably less risk for abatacept or rituximab. And that the emerging data with JAK inhibitors suggests there is risk. The bottom line is there in red: screening prior to immunosuppression. I don't care if it's prednisone or methotrexate or any of these drugs. When someone is likely to be immunosuppressed for a long time period, i.e. they're newly diagnosed with RA or psoriasis or something like this, I would take the time to screen them while they're relatively immunocompetent and understand what their TB status is. That's an important thing to do, and I think that's just something that hasn't been done historically, and we're playing catch-up. So it's harder to screen these people once they're immunosuppressed. Our tests just don't work as well in that setting. Screening in the biologic setting, these are my words to live by. Number one, a priori probability reigns supreme, and this is how I think about it. This is very George Bush-like. It's pretty black and white, but if they should be positive, then they probably are, and if they shouldn't be positive, they probably aren't. That's how I think about it. And if they should be positive and they're coming back negative, I often repeat my test because I know they should be positive. I don't believe it. If they have risk factors, then use 2 screening tests to maximize your sensitivity, particularly if they're immunosuppressed. And again, if you don't believe your test result, repeat it. And that's true of any test in medicine. We're all taught that in medical school. This is a partial list. My fellow and I published this article in CID. I think there's another table alongside this, but it doesn't matter. You can see that it's overwhelming, that these are all drugs in phase 2 or phase 3 trials. Some of them are very close to approval, and just to show you that, lots of names you can't pronounce, numbers and hyphens and things like this, you don't know what they're going to be called. The bottom line is, again, immune modulatory or immune-mediated inflammatory diseases such as lupus, RA, Crohn's, etc. But you can see the different targets. We have a slew of anti-IL-17 drugs coming, a slew of JAK inhibitors coming, and you have all these other targets, 2 IL-6 targets, IL-21 targets, etc. So this is an expanding field, and it is interesting and exhausting to try to keep track of it. Last, another shameless plug for NTM. This was a patient who was on infliximab who developed pulmonary MAI and was switched to etanercept thinking it was safer, and they were put on 4 drugs for MAI, and they just went downhill and developed large cavities and really behaved differently than most MAI cases in terms of really rapid progression, and they died. And this was Mike Eisman's patient who he enlisted my help with, and so thank Mike Eisman for donating this slide. The point is, again, in the U.S., we're just as likely or more likely to see NTM in this setting, so keep your eye out and be vigilant. And there's really no way to screen for NTM necessarily, so it's different than TB. It's not necessarily as preventable. So that ends my presentation. I'd like to acknowledge my friends that helped me with all this work, and Dave Ashkin and his crew in Florida here for inviting me to give the talk, and I'm happy to spend a few minutes taking questions. Thank you.
Kevin, that was simply outstanding. Thank you so much. We have a couple minutes for questions, Kevin, if that's okay with you. And I guess if it's okay, I'd like to start. We had a number of questions about, the whole idea of, as you're bringing up the possibility of developing, especially in high endemic areas, TB while you're on therapy. And a couple of questions, participants were asking, what are your recommendations? Like, should, and again, we're in a low-risk area, but among, higher risk, I guess two-part question. Here in the U.S., do you continue to screen your patients on the on tumor necrosis factor blocks or biologicals throughout their treatment, and if so, how often?
Yeah, that's a great question. So When I was at CDC, we wrote the screening guidance around this MMWR talking about, and we did not, this was a while ago, it was like 2005 or 6, we did not recommend repeat screening. We thought people should be screened, and in the absence of risk factors for new infection, there was no reason to repeat their screening. I still feel that way. I think that's consistent with how we as TB people approach all settings of immunosuppression in the U.S. I don't know any setting where we're repeat screening people on a yearly basis in the absence of risk factors for infection. So for example, HIV patients in Oregon, we screen them once, we don't screen them again unless they're homeless or unless they're in jail, unless they have a risk factor potentially for being exposed. So my belief is that the same approach should be used here. I think most of the patients in the U.S., once they've been screened and their status is known, they go on these drugs, they don't need to be screened again in a year. Again, that's a soapbox issue. I usually get on it when I talk around the country to rheumatologists or dermatologists about this. That being said, there's some people that travel to India to see grandma. There's some people that work in homeless shelters. There's some people that are at risk. And so if you're at risk for new infection, then some periodic or repeat screening seems reasonable, particularly if it's pegged to the potential exposure. And so that's something that should be considered with every patient. I can tell you that the FDA labels of these drugs say that patients should be screened at baseline and then again periodically. And when they wrote that, I don't think they consulted us at CDC. That's my recollection. And I think a lot of rheumatologists feel bound by that label saying, well, I have to repeat their screening. And so they do that. And I often see people get into trouble with it because they end up with a false positive, in year 3. So my patient's been on infliximab for 3 years. They grew up in Oregon. They've never left the state. And now I've got a positive IGRA or a positive skin test. What does that mean? Well, it means you shouldn't have screened them. They were negative the last 5 times you screened them. Why are you screening them again? So I think you can get into trouble when you're screening people that don't need to be screened.
No, I agree, Kevin. And along those lines, a couple questions also we're asking about. One, we know like this is always the question with HIV. Everybody knew that once you were infected with TB, your chance of progressing from infectious disease was increased. But one of the big burning questions is, well, what about if you are exposed? If an HIV-positive individual is exposed to somebody with TB, do they have a greater chance of going on to TB? Because as we know, only 30% of all individuals who are in contact with an active case traditionally become infected and go on. Is there any data whatsoever that patients on tumor necrosis factor blockers are more susceptible, meaning, if they are exposed, have a higher chance of becoming infected and developing disease?
So as distinct from someone who's got latent TB and is reactivating or progressing to active TB?
Right.
Yeah, that's an interesting question. There's certainly animal data that speaks to the answer being yes. If you're on a TNF blocker and you're newly exposed, you are at higher risk to developing TB. That's a hard question to answer in humans. Outside of an experimental setting, it's often hard to figure out from these studies whether the people are reactivating or, progressing from latent to active or if they're being newly infected. I think the answer is definitely yes. I mean, because you can look at these studies where there's patients from India and other places, and, they develop TB, 2 years after starting their TNF drug. It's definitely plausible that that's a person with latent TB that has now progressed, but it's also maybe as likely or more likely that that's a new infection, as distinct from someone who, develops TB 3 to 6 months after starting one of these drugs. That's probably more likely, particularly if it occurs in the U.S. or somewhere where there's very little TB transmission going on. The chance that they've been newly infected is almost zero. It's much more likely to be a case of progression from latent to active disease. So I think your question is a good one. There's really no experimental evidence to answer it, but I think intuitively and how we know how these drugs work and how they would interfere with granuloma formation and really actually control, I didn't get into the macrophage, but really it's about control of the TB bacilli in the macrophage. And I think, the interference of that process in the context of a new infection would almost certainly argue that the patients are at risk in that way.
Yeah, exactly. I mean, I think even now, still the HIV, just like with HIV, it's still out there. I mean, you would hope that with all the fingerprinting data now that we're collecting, it may be better, answered, but still, like you said, it would be very difficult. So first of all, before we go any further, if anybody has any questions they want to ask Kevin live, we'd love to hear your voice. Just all you have to do is push *7 to unmute. That's *7 to unmute, and then *6 to go back on mute. But in the meantime, let me ask one question, and then once that question's open, just cut in and say hello. But real quickly, the burning question, Kevin, by far, is the famous question I think all of us as clinicians get all the time, which is, when do you start the tumor necrosis factor blockers? Because I think you agree, most of these patients are really, really ill, and they're anxious to start. And traditionally, we've always talked about it's always been up in the air, anywhere from 3 to 8 weeks, depending on if you look at all the international standards. Many people say 1 month, but in reality, there are also, I know with the Golimumab, and I botched that name. I did not practice nearly as much. I know in many of them they started immediately and they did okay. Any firm studies or anything that really looked at when's the best time to
Yeah,
start?
that's a good question, a frequently asked question. So most of this 1 month gap between starting LTBI regimen and starting a biologic, it's all come from that Spanish study, and I think most of us just adopted because that was the evidence, that was the data. There's a variety of studies, including the Golimumab studies I showed you, as well as there's other studies, the Westoven study, and there's a number of studies now that have shown that's not necessary. I mean, you can start these things simultaneously. And so I feel very comfortable that that's the case. But I can tell you that that functionally, it's always nice to know someone's actually picked up their INH or rifampin, whatever you're using, and actually start taking it. So I do argue that some sort of gap is useful, and that's really to make sure someone's actually taking their medicine before they start one of these drugs. I have had patients who started their TNF blockers, they come back 4 to 6 weeks later for a follow-up visit, and they haven't even started their INH yet. And I'm saying, gee whiz, guys, I thought you started this a month ago. And they said, no, I just didn't pick it up. So I like to know that they've started it. So I think some gap of 2 to 4 weeks is very reasonable. And actually, it almost always plays out that way because people have to get approval to use these biologics. They're very expensive. It often takes several weeks to arrange. So usually there is a gap, even if you didn't want one.
So towards that end, we have a couple questions about INH and rifapentine, and I guess the question is, do you still wait even 1 month with the INH and rifapentine, especially since, one advantage in some ways right now is the recommendation is for INH and rifapentine to be given by DOT. So there is kind of an advantage that you will know those patients are taking it. Do you still, Kevin, in general, wait a month when using that regimen? I think functionally the way it plays out is generally there is some gap. I don't know of any data. No one's studied this, so I can't tell you like I can with a daily regimen, like example from the Golimumab trials, that it's okay to do. But I think, theoretically it should be, and I think some sort of gap, again, makes sense. The way I do it in my practice, I usually start people and I have their first dose observed, and then I say, okay, you can go ahead and start your biologic, and it usually takes a few weeks before they can get it. So there's usually at least a couple-week gap. I do like to know that they're tolerating the 3IR. Not all my patients tolerate it. I'd say 15 to 20% of them have significant fatigue surrounding the rifapentine dose, for the next 24, 36 hours after they take their weekly dose. I've had a number of people quit the regimen because of that, and a lot of these people are older individuals, so not everyone is willing to go forward with that. So I kind of like to know, again, that they're on it and they're willing to keep taking it before they start their biologics. So I think some gap of at least several weeks is useful for that. And I agree, but though I have to say I totally concur with the side effects profile with the INH rifapentine. But it's always amazing when I say, well, okay, well, I guess your alternative is 9 months of INH, and how quickly that fatigue just clears up. But towards that end, I mean, a couple of people saying, in your experience, who ends up treating these LTBIs? Is the is it the treating physician, like the rheumatologist or the dermatologist, or are they getting referred to the health department or the private?
I think few of them go to the health department. I mean, I treat a lot of people like this, and I have colleagues that do this. I think a lot of these people get referred to ID or, in some cases, pulmonary, particularly from the dermatologist. I think the rheumatologists, some of them will certainly treat the LTBI themselves because they feel comfortable doing it. But the derms, I think, are less comfortable. They're not internists like the rheumatologists. So I think probably just from a background standpoint, they're more likely to refer.
I appreciate it, Kevin. So for a second now, let's just wait. Anybody want to ask Kevin a question live? That's *7 to unmute. *7 to unmute. I know Mark Lobato's on. He has a question. He always likes to speak. Mark, are you there? Well, Mark's question was, I'll ask it for him. So in your example about your high-risk patient, you talked about using, both a IGRA as well as a skin test. His question is, in that example, would you use 2 IGRAs? Because that was kind of what you would talk about. So using 2 IGRAs and, meaning the T-spot and the quantiferon, or just one?
Yeah, so that's a great question. And so, if you go back...
Don't give Mark credit for a great question, because if he didn't ask it live, he gets no credit. That's
okay, it's not a great question, Mark. But I think it is something to think about. And here's what I think. That French study I mentioned, this is essentially what they did. They used the skin test in both IGRAs, but they ignored the skin test results. And they ignored them because almost everyone in that study had a BCG history. And so what they essentially did was a dual IGRA screening approach. I definitely advocate that in people who have a history of BCG, who are immunosuppressed and have risk factors for TB. So the example I gave, which I think he was asking about, was my guy from the Philippines, which I use a skin test and I use quantiferon, and I did so at the time because I don't think I had access to the T-spot. But now having access to it, if I did that over again, I might have used both IGRAs instead, because I do think that's a very reasonable idea given the gentleman had a BCG history. So that's a good question, a good thought, and I agree with Mark on that.
Don't say that. But hey, towards that end, so here's my question to you. So practically, a lot of these patients are coming to you on prednisone or other agents. And what I found in a number of these cases when they're coming to me is that when I go to do the quantiferon, I get indeterminate results because their mitogen is low. So I guess here's my question to you. So do you see any advantage, and again, this is not one preference for one test or another, but do you see any preference in like using the T-spot over the quantiferon, or do you see similar results, or again, you're doing both, but in those kind of situations with an indeterminate, do you think maybe going to a T-spot just to see what you get may be an advantage?
Yeah, I think if you look at the data and the studies where both those type of tests have been employed in screening these type of people, that most of the time they concord pretty well. And of course, there's no gold standards. You don't know who's right and who's not right in these individuals where there's discordance. But most of those studies, they concord pretty well. If I had to be pinned down, I'd say, yeah, maybe the T-spot's slightly more sensitive, but maybe it's also slightly less specific than the quantiferon. That would be my kind of assessment from looking at all the literature across all settings. But from a clinical standpoint, I think they're very similar, and I don't really distinguish between them. I think if you get an indeterminate test on the quantiferon, I think repeating the test with a quantiferon or a T-spot or a skin test, these are all reasonable ideas. I mean, you should repeat that test, and picking the same or a different method to repeat, these are all reasonable approaches, and so I would advocate any of those.
So then, and I really liked your slide, Kevin, a lot about clinical, that, you can increase the performance of these tests by your pretest probability. And I think a lot of us just don't think about the pretest probability enough because it really enhances the positive predictive value. And I guess I would ask you this, Kevin, and you made a statement, and I think all of us are stuck in this. So I get somebody who comes from a high-risk country, and I'm about to start a very, very potent immunosuppressant. Do I really got to do the test? I mean, the bottom line is, how often are you just going to start just because you just feel that these tests are going to be, quote unquote, falsely?
Yeah. So that's a good question. It gets back to my Philippines guy that I talked about. I mean, I ended up just treating him empirically anyway, and I ignored these negative test results because I didn't believe them. This would be consistent with the 2006 British Thoracic Society recommendations, which were just that. It's just if someone comes from a place where it's likely that they have TB, why even screen them if you don't just treat them empirically? That's not an unreasonable approach. I still think you should screen them because I think it's good to know what their screening tests are or were, because it helps you understand or potentially interpret future screening test results. So I would get them. I disagree with the BTS guidance in that regard, but the idea of, geez, they're at high risk, I don't really believe the screening tests because they're immunosuppressed, I'm going to treat them anyway. It's hard to argue with that, and I've done that before, like the example I gave, and it just depends on what you think their ultimate risk is and what the patient is comfortable with. And I have to say, having the new 3IR regimen, it makes treatment easier, and it makes the chance that you're complete higher. It may push me towards treating more people because of that, because that benefit-risk equation may be slightly different.
Right, and I mean, and obviously, I totally agree with you. I mean, and there's also some information you actually may get from the quantiferin and the T-spot that actually may be helpful. It does give you some indication if the T cells are responding. Now, what clinically that means, we don't know.
Yeah.
Kind of gives you some information. So,
I should add one more thing, Dave, because when you ask the question about repeat screening, and a lot of people repeat screen these people like we discussed, but a lot of times they use one of the IGRAs, and I just want to put that out there that that's fine, and that's what I would do too if I was repeating someone's screening test. But TNF blockers downregulate the responses that those tests measure, and so there is data. There's 4 or 5 studies now that suggest that you do see false negative IGRAs in patients who are already on TNF blockers. So that's always something I think about when I have a patient who is being screened and they're already on a TNF blocker. So it's something to keep in the back of your mind.
Yeah, no, definitely, and and again, you do get some sense of that too when you do these studies. When you're looking at those mitogen responses, you really do see them drop off once they start if they do repeat it. So I guess one of the big questions we're getting, because we're running out of time, is peds. We talked a lot about adults, but in kids who are going to be started on some of these agents, especially those with like juvenile rheumatoid arthritis or other issues, do you use the same screening, and are you seeing kids being started on these agents?
Yeah, I mean, certainly kids do get these agents. It's pretty rare, though. I mean, JI is pretty rare. Most of these kids are born in the U.S. Most of them have no risk factors, so it's the risk of TB is pretty low. Just knowing all that, they should still be screened. I always say that if you want to screen a kid for any reason, you ought to use an IGRA and a skin test. You should use them both. I mean, if you really want to know what a kid is, you should improve your sensitivity to your greatest degree, because none of these tests are probably as sensitive as we want them to be in really young children. So I would dual screen a kid, particularly if they have risk factors. If they have no risk factors, I'd be less excited to do that. But again, most of these kids aren't under age 5. I don't know of kids under age 5 getting these type of drugs. You'd have to ask a pediatric rheumatologist, but I haven't run into that because most of these entities, occur later in childhood.
Kevin, I cannot begin to thank you, and on behalf of all of our listeners, we so want to thank you for such a great presentation today, one that I'm sure everybody will, if they haven't already faced, that they're going to face real soon. So Kevin, thank you so much. We can't thank you enough. For those questions that weren't answered, if you still want the answer, if you would email us, we'll get that to Kevin or one of us, and we'll try to answer your questions. Other than that, Kevin, thanks again for everything. Megan, I'm turning it back over to you. Maybe I'm not.
There you are. I'm here. Sorry about that.
Sorry, Megan, go ahead.
Yeah, we just want to thank everyone for attending today's Grand Rounds webinar.